Okay, so am I audible, ma'am?
Yes, you're
Hello.
audible. Your screen is
Yeah.
also visible. Yes.
Okay. Okay. So the first question is an MCQ. One option is correct. So which of the following conditions in the newborn is not a manifestation of IgG antibody crossing the placenta? So all of these are the conditions. The first option is myasthenia gravis. Second is neonatal thyrotoxicosis, HIV infection in the newborn, and hemolytic disease of the newborn or erythroblastosis kind of phenomenon. Okay, since this was a short question, most of you must have read the question. So the correct answer, as many of you have predicted, is C. So in neonatal myasthenia, actually we have IgG antibodies which are directed against the acetylcholine receptor and sometimes less frequently musk receptors also. In neonatal thyrotoxicosis, it is against the thyroid stimulating antibodies and it is again IgG antibody. But in HIV, the transmission of HIV virus itself causes the disease. So this is the correct option, and that's why we use DNA PCR to diagnose such cases. Okay. So moving on to the next question. So this is echocardiographic view, and the first question is identify the echo view and the structures labeled as A, B, and C. Name 3 echo markers which decide need for treatment in such cases. Name 2 most common drugs used for this condition and arrange the drugs according to efficacy, dose, and best route of administration. Yeah, keep on entering your answers in the chat box. Okay, many have entered the answers and drugs used for these conditions, the 2 most common drugs. Okay, and which route would you give or prefer to give the drug if the baby is kind of stable or is accepting feeds? Okay, let's look at the answers. So many of you have got the echo view correct. So it's a PSAX view or the parasternal short axis view with RPA, LP, and PDA. So this is the RPA, this is the left pulmonary artery, and PDA. And if you put the color Doppler, you can see what is called the tripod sign because all the 3 structures lie side by side. Okay. Uh, Echo parameters, as you have guessed it, that if it is a hemodynamically significant PDA, PDA size, large PDA size would be classified on the basis of size more than 3, LAO ratio more than 1.5:1, a pulsatile flow, which signifies a non-restrictive flow, and diastolic steal. So diastolic steal again can be seen in various arteries. descending thoracic aorta, cerebral artery, or the renal artery. So these echo parameters can help determine whether the PDA is hemodynamically significant or not. The drugs which are very commonly used are ibuprofen and paracetamol. And if you look at the efficacy trials, Brufen has shown to have a better closure rate than PCM, though many studies have claimed that PCM is also non-inferior to Brufen. Again, if you look at the route, oral route has been preferably shown to be more efficacious than the IV route. So this is a thing which you can make a note of. So if a baby is not improving on PCM and if he's on feeds, you can very well give a trial of Brufen. And nowadays, high dose Brufen trials are also being given. So instead of the 10-5-5 dose, you can also give the 20-10-10 dose if the baby is kind of tolerating that dose. So moving on to the next question. It's a short MCQ. So you have to choose the false statement. So most babies are cyanosed at birth. The second option is fetal brain can use ketones as alternative fuel if glucose supply is interrupted. The third option is cord blood arterial pH will be same or higher than the umbilical vein pH. And fourth option is when uterus contracts, blood flow through the uterine artery may be interrupted. So which among these is false? Okay, I think everybody has, most of you have got the correct answer. So if you look into the fetal circulation, so the umbilical venous blood has a higher oxygen content than the arterial blood. So the cord blood arterial pH would always be lesser than the umbilical vein pH. So that statement is wrong. Other statements are right. So the next question is, so you have a figure and a term newborn with birth asphyxia was attached to a monitor at 60 hours for persistent encephalopathy and following waveform was noted. So you have to identify the modality being used or being talked in this scenario, interpretation of this particular waveform which is on the screen, and what are the possible waveforms other than this which you can get in this modality being used. What is the utility of this procedure? Any three uses of this procedures and three pitfalls of this procedure. Uses or the utility of this procedure and the pitfalls of this procedure. Any three. Okay. So many of you have got it correct. So it is amplitude integrated EEG monitoring, or also called as cerebral function monitor. So this diagram, you can see that the baseline is raised from 10. So, and it is touching as high as 100. So this particular waveform is kind of indicative of seizure activity, as can be seen in the EEG also. What are the other background patterns? So you need to know, if you can remember, this is a Hellstorm Vestas classification. And if you remember it in an easy way, there can be a normal waveform, there can be a moderately abnormal trace, a severely abnormal trace. So these are the background patterns which we can see in an aEEG study. So normal pattern, all these patterns are determined by the lower margin and upper margin. Okay. So lower margin, if it is more than 5 and upper margin more than 10, it would be classified as normal. And moderately abnormal, if it upper margin is more than 10, lower margin is less than 5. And severely abnormal if both the margins are less than 10 and less than 5. So a very subdued waveform. This indicates flat trace or low voltage. And in the moderately abnormal waveform, burst suppression can come. In the moderately abnormal waveform, though discontinuous normal voltage has been classified, but in some babies in the initial period, this can be a normal phenomena when the baby is sleeping. And continuous normal voltage is obviously the kind of normal thing in a term newborn. So three utilities of this procedure, obviously we can diagnose seizures, electrographic seizures, long-term prognostication also this thing can help. So in this baby, the background pattern was showing burst suppression pattern, and the baby had seizures also at 60 hours. So it is said that if within 48 hours a normal sleep-wake cycling doesn't come back, it is associated with poor prognosis, and the baby was encephalopathic also. And in some cases, in cases where it is difficult to decide whether TH is to be given or not, in those cases when the pH is borderline around 7, the base excess is -15, -16. In those cases, we can take help of aEEG also. And if the waveform is moderately abnormal or severely abnormal, we can go ahead as a candidate for TH. So pitfalls. So this modality is prone to ECG artifacts, movement artifacts, and short seizure activities are often missed in this waveform, because the gold standard always is the full EEG and not aEEG. It is easy, and that's why it is being used so well. So the next question is a small MCQ. So which is true about newborn skin? So which is the true option? So the first option is pustular rash occurring within 72 hours of birth should be treated with acyclovir. Hemangiomas tend to respond well to propranolol. The third question is congenital melanocytic nevus more than 3 mm need removal due to risk of malignant change. And cutis aplasia vertex can be associated with the use of scalp electrode. So which of this is true? Okay, so many of you have answered B. So B is the correct option. So pustular rash occurring within 72 hours of birth, as you most of you know that transient neonatal pustular melanosis can present at birth, and even erythema toxicum neonatorum can also have a pustular variant. So that can be a common entity in newborns in the early period of life, and definitely all pustular rash should not be treated with acyclovir. Hemangiomas tend to respond well to propranolol. That is a true statement. In congenital melanocytic nevus, though there is a inherent chance of transformation into a malignant change, but that probability lies with the giant melanocytic nevus that is more than 20 size. Okay. The cutis aplasia vertex is often associated with genetic causes only. So scalp electrodes, etc., are not the contributing factors in this. So the next question is a question from statistics. So identify the figure. So you can see various squares mentioned here, and there is a big diamond. There are horizontal lines in the figure, and there is a vertical line. So what do the squares, horizontal, vertical line, and the diamond indicate? In this particular figure, you can see that there is a I square value mentioned. So what is the interpretation of this I square value? And what is the overall interpretation of this study? So you can see that an entity called risk ratio has been mentioned. So what is the interpretation of this analysis? Many of you have named the figure. So what is I square? What does it indicate? If anybody can mention that. And how would you interpret this result? Okay, so let's look at the answers. Many of you have answered the identifying the figure. So it's a forest plot as rightly mentioned by many of you. So this is seen in meta-analysis. So if you see the squares are mentioned in individual studies, and the square determines the weight of the study. So more the weight of the study, the bigger is the square. And one of the contributory factors, as somebody mentioned, is the sample size. If bigger the sample size, more is the probability that the weight of the study would be more. The diamond, which is at the end, so it's a pooled estimate of the overall estimate when the all the results of these individual studies were combined to give a synthesized a single outcome. Okay. So if you look at the horizontal lines, which are kind of extending from the square, so these are 95% confidence interval. Similarly, if you look at this diamond, the tip, the left and the right tip of the diamond is indicating the 95% confidence interval in this case. So if you can see here, I square. So I square is also called the heterogeneity. So you always see that in a meta-analysis or a systematic review, number of RCTs or number of studies are combined together. So whether these studies were homogeneous or heterogeneous, it is determined by this statistical term, which is I square. And more homogeneous the result, the better would be the validity of the meta-analysis. So if the I-square value is more than 50%, the study is considered to be statistically heterogeneous. Okay. So here, if you can see the inference of this study, the diamond lies to the left side and it favors the corticosteroid. But in these kind of studies, always when you interpret the risk ratio, don't blindly just go ahead with the risk ratio, because you have what matters is the 95% confidence interval. So in this case, as you can see, the 95% confidence interval lies to the left of one, and it is not crossing the line of no effect. So antenatal steroids, 31% reduction in moderate or severe RDS, as 95% confidence interval did not cross the line of no effect. Okay, so the next question is a figure. So you have to identify the figure and study type. So what are the 4 basic steps involved in this type of study? How are the results communicated in this study? And what is a PDSA cycle? Okay, so many of you have got the answer correct. So fishbone chart, fishbone analysis, as I can see in a QI study. So fishbone analysis in a quality improvement study. So in this study, there are 4 basic steps. First, we identify the problem, as in this case, the problem was antibiotic exposure per baby, and the aim was to minimize the antibiotic exposure. So we identify a problem, form a team, and create a problem statement. In the second step, we analyze the problem and measure the quality of care. So for that, we use fishbone Pareto principle in 5 ways. You can read about these things. In the third step, we develop change ideas and we implement those change ideas to see whether what effects are we are getting in our system due to those changes. And one of the most important step is sustaining those improvements. Once you get an improvement, you also have to sustain the improvement. So the results are displayed in these kind of QI studies in the form of run chart and control chart. If you look at this run chart, it is kind of a very simple chart that displays data over time. So here you have the data in the x-axis, and in the y-axis you have the measure of interest. So it can be anything. So you get a kind of visual impression whether the measure of interest is improving or not by the intervention over a period of time. Now, what is a control chart? In a control chart, in addition to this, you get what is called the upper control limit and the lower control limit. Now, when you are conducting a QI, there can be a number of variations. Okay. So there are some common cause variations and some special cause variations. So if your QI is to be believed upon, it should lie between the upper control limit and the lower control limit. So this is a better way of presenting a QI data. So you can read about these 2 charts. And as many of you have predicted, so PDSA stands for plan, do, study, and act. So we plan certain things or objectives to be accomplished, we plan the data collection, then we do the changes, implement the plan and observe and collect data. Then we study what we have collected and we analyze the data, and we act upon for the next cycle and what changes are to be made next. So in a QI study, it is very well possible that you may end up with 5, 6, 7 PDSA cycles, multiple PDSA cycles. So the next question would be the last for today's session. So this is a 35-week baby who was born by vaginal delivery after preterm labor to a mother with meconium strained liquor. She had 4 episodes of central apnea within first 6 hours of life requiring stimulation. In between, her SpO2 remains 96% and examination is normal. So what would be the next step? So would you like to place her in 30% oxygen because she is having apnea? Commence caffeine for apnea or prematurity, intubate and ventilate, or start antibiotics? Okay, so I can see variable responses. So some people would like to use 30% FiO2. Many of you would commence caffeine. Some would like to even intubate and ventilate the kid. So I think I need to call out Alicia earlier, who has mentioned D, and she is correct. So you need to pick up subtle points in this question. So this baby is born preterm and there is preterm onset of labor. We don't know the cause why this preterm onset of labor happened. And that too, meconium strained liquor was there. So a preterm presenting with meconium strained liquor with a preterm onset of labor, always think of uh, a possibility of early onset sepsis in such cases, because MSL in a preterm baby is quite abnormal and uncommon. Moreover, as you can see that the baby is still in the first 6 hours of life and is having apnea. So if you know a little bit of physiology, the maternal progesterone level in the first 24 hours of life acts as a respiratory trigger and respiratory stimulant to the neonatal brain. So in apnea of prematurity, it's very rare to get a baby with apnea presenting with recurrent apnea in the first 24 hours of life. So if you have a baby who is preterm, who has a preterm onset of labor with MSL, and within 24 hours of life, the baby is having recurrent apnea, so you would always have a probability of sepsis and you would start antibiotics after taking a culture. And since this SpO2 is remaining 96%, so there is no point in placing her in FiO2, as you can cause a free radical injury. Obviously, the baby does not need oxygen at this point of time. Okay. So I hope you enjoyed the OSCE session and you can read about the answers which you found a little unheard of or you can improve upon.
Thank you very
That's
much,
all
Dr.
from
Ankit.
me.
I think it was a very, very interesting and useful discussion. I can see Dr. Kiran has already posted that the questions and your discussion of the third case was very useful. And a recording of the YouTube link of today's session will also be available on the FEAT platform, as all students may be aware. Thank you so much, Dr. Ankit, for taking out your time, and thank you all the students for joining us. And we'll hope to see you all soon on the next week's FEAT session on 17th May. Until then, good night and bye. Take care.
Thank you.
Thank you. Good night, everyone.